Mr. Secretary, thank you. We'll now have a round of questions, and I'll begin those questions. First of all, one of the experiences I've had over a long period of time is I have occasionally been able to get the Department of Veterans Affairs' attention on a particular veteran and his or her problem that needs to be addressed. I've also, from time to time, been able to encourage and been assured by the VA that certain policy changes that made no sense to me and to others were being corrected. In both instances, I want to indicate that the end result is not the result I was totally looking for. And so fixing a veteran's problem never meant it fixed anybody else's problem who may have had the same circumstances. So that's one. And then policy changes, I discovered that the VA, the Secretary, and others would tell me that, no, we've changed that policy, but only to go home to find out that no one in the VISN, no one in the hospital knew about the change in the policy. Will your reorganization address and solve those kind of problems?
Mr. Chairman, I couldn't have done it better in 1 minute to describe why we're doing what we're doing. You just described it from every member on this panel and every member that's not on this panel, is finding a solution to the individual problem that should solve a policy problem but does not. And that's why we actually have the problem that developed in this over time. And I'm not going to go back to any prior secretary or even prior administration, both Democrat or Republican. I think there were good intentions all along. But when you get an internal growth and you have a department so large that they can't basically move because of internal frameworks, this is where we get the problems. I would like to, Mr. Chairman, I want to address Greg Goins, who's been a member almost 14 years in the VA, working at a VISN level, working at a hospital level. Greg can talk about how what you just talked about was so difficult when you had policy taken in one place and never applied in the hospital level.
Thank you.
Yeah, thank you, Mr. Secretary. So in my time as a medical center director and also a VISN director, now in this role as an operations officer for VHA, it's very clear that there's a lot of silos within our organization, and that ultimately creates a lot of disconnect, both between what's actually drafted in policy and also the guidance that's being given from those subject matter experts. And so as a result, it's very common in current state of affairs for a frontline worker to be engaged with a veteran and have a challenge with something that might be written in policy or something that might have been given in guidance. And when they try to get clarity on that, they might get 5 or 6 different answers depending on who they go to, between the program offices, the VISNs, even their medical center director. This new organizational structure creates a new element that does not exist currently, a medical operations center. That medical operations center's focus is to take policy from the DC level and interpret it so that there is one application to the way in which that should be implemented. Nothing pains me more than when I'm serving a fellow veteran and I get a call, maybe it's from you or somebody on your staff or maybe somebody in VACO, and I need to address the challenge that individual veteran has, but the pain that I have knowing that this could happen to someone else. This organizational structure change, this management redesign is going to allow us to create continuity from the top all the way to the front line and allow us to flag those type of events proactively so that the communication to the field is consistent so that we fix those things and escalate them real time.
Thank you for that answer. One of the aspects of reorganization that you are addressing are the VISNs. It took me a long time to learn that the VISN was not really supervising the hospitals with direction or capability, responsibility for doing so. I always, in my early days, assumed that the VISN was the overall arching leadership when it came to the hospitals within that VISN. Your RISE Act indicates that we will reduce the number of VISNs from 18 to 5. VISNs, just the reduction in and of themselves, is insufficient unless the VISNs have purpose and meaning, relevance. What problem is the consolidation of VISNs under RISE intended to solve? How will specific roles and responsibilities of the VISNs change once RISE is implemented? And what benchmarks will the VA and this committee be able to use to evaluate whether the new VISN system is resulting in better outcomes?
Mr. Chairman, just real quickly on that, that was part of the problem. We had a VISN structure that was not, in fact, there's an article today out of Georgia, my home state, of Dublin VA Center, in which it showed the inadequacy of the VISN system in seeing a problem but not acting on a problem, and that was a policy decision and the way this happens. John Bartram is our new Undersecretary of Health who will be actually over this. What we've actually done is we've taken the 5 divisions, then also added HSAs who then can actually do more market-centered for your rural hospitals, your urban hospitals. They're more directed into how they can actually help those hospitals and give them better direction, while the VISN level is now concerned with actual implementation and management of that. And I want the Undersecretary to discuss
Secretary
that.
Bartum?
Yeah, sir, thank you for this opportunity. I really look forward to implementing this change across the department. But the scope of the VISN directors, as you're talking about, is too broad. And we've got to focus that down so that they're doing the executive level work and the strategy of looking up. And with the health service areas, those HSAs, they're looking down at more narrow markets. And they're still working for the VISN director. But now they're able to focus on what is going on and help support that hospital director. So that support directly down to the facilities is providing that support so that we can assist the hospital director as opposed to add bureaucracy to the process. I realize I'm over time. I didn't want to go any longer unless you want me to, but Greg Goins can give you a little bit more in depth as a former VISN director of the perils that he had to face in that role.
Mr. Goins, I was reluctant to ask my question in the manner which I did because I didn't want you to seem to yourself irrelevant.
No, sir, I did not feel that way at all. In fact, I think in the last several years of being in that role, I celebrate the opportunity to correct this and to improve it for our veterans and our employees in particular. As a VISN director, a day in the life of, very much of your time is spent trying to compete with multiple responsibilities. Okay, that's fine. If you're an executive, you expect that. The issue is with the scope of responsibility being governance and oversight and appropriations, et cetera, every time that you spend on that, every day of the week you spend on that, it's a day of the week you cannot spend in community stakeholder engagements, medical center engagement, medical leadership engagement, veterans and their families engagements, and also engagements with our local partners like yourselves, our legislative partners. So what this redesign does actually is it de-scopes the role of the VISN director to focus on the oversight and governance aspects of that role in one place. That's those 5 VISN directors. Then we have these new elements within each VISN called health service areas, and those health service area directors, their sole responsibility is to focus on the day-to-day interactions with the medical centers and their leadership teams, along with all those community stakeholders I mentioned. It gives them an ability to understand real-time the challenges that are happening in the facility and also work real-time with those facility directors and their teams to resolve those challenges without having to go up and down the chain of command.
And sir, if I might add, the other aspect of this that sometimes gets left out is currently the VISN directors don't report up to the undersecretary. This streamlines that. So when people talk about bureaucracy, this streamlines the bureaucracy so that the VISN directors will report directly to me. And so that allows me to have better access to what is going on in the field and where there are issues, just like the MOC director as well. So instead of having this bifurcated system where we go through all of these different channels, the Undersecretary for Health will have the 5 VISN directors and the MOC director, and then his 2 deputies, the principal and the deputy. So it'll be a much tighter team to be able to implement future changes.
Thank you all for your answers. Senator Blumenthal.